Ready. I think we're ready. We're ready
For me
we're
to
ready to
convince her
start.
that she needs
Yeah,
to go.
Clara. I think we're
Yes.
ready to
Okay.
start. Okay. Good afternoon and welcome to our Heart Café. I'm Juan Carlos Kasky, Professor of Cardiovascular Science at St. George's University of London. My co-chair is Professor Clara Saldarriaga from Colombia. We will introduce our panelists in a minute. We are very grateful to the World Heart Federation and Servier for having organized this fantastic meeting that gives us the opportunity to discussing an absolutely key issue in cardiovascular pharmacotherapy, which is adherence to medical treatment. It's really quite staggering, the fact that when you think the proportion of treatments that fail, mainly because adherence is not considered as part of the global sort of strategic point in giving treatment. So we have this time the opportunity of discussing not just among physicians. This is a topic that physicians very often discuss, but with this time we'll have the opportunity of listening to the patients, which are the barriers they perceive for treatment adherence, how they feel we are actually conducting our suggested treatment. So this is a unique opportunity again. So Clara, if you would like to say a couple of words, introductory words, and perhaps introduce our panelists.
So thank you, Professor Kasky. It's a real honor for us to have our experts for today. So let me introduce Maria, Max, and Steven. They are our expert patients that today are going to explain to us their experience, how it is to live with cardiovascular diseases, and I think this is a wonderful opportunity to be from the other side. We are just always thinking about diagnosis, but what about the patient's perspective? So we can move on to this very interesting session.
Right, so I may take the opportunity perhaps to start with Maria. As I said before, cardiologists, physicians, we discussed why our treatments are not as effective as they should be. And we always come to the point of patient adherence. So, but in your view, which are the main barriers you actually find for treatment to be effective? I mean, why do you think patients are not necessarily following the sort of indications for treatment? So perhaps you will tackle some of these things, but you give us your perspective on this.
Yes, gladly. There are many, obviously, and varied ones, and it differs between patients. But some of the ones that strike me as being most important, we have forums of patients, so we've got a collective view, if that's helpful. One of the main things is multiple pills. Lots of patients have lots of pills. They don't just have one heart medication. They may have several heart medications, but they may also have other tablets that they're taking for different conditions too. That was one of them. Another one is not managing on medications. So if you've left the hospital with a new medication, let's say, and you go home and try it, perhaps it makes you feel worse rather than better. So can there be a callback of some kind, rather than leaving you for, say, 6 months for the next appointment? Because from a patient perspective, they won't know whether to continue with that medication or stop. So the likelihood is they'll stop. So they're not then on anything until they next go for the next one.
So basically that takes us to these two important points. One is
Yeah.
the number of tablets that are
Yeah.
necessary, and most treatments now require lots of tablets.
Yeah.
Would it be possible that communication is a problem there? Because I always try to make an effort to explain to the patient what this tablet is
Yes.
for. Can you elaborate on the problems of communication and understanding the mechanisms of the disease?
Very important, because knowledge is power in everything, and it certainly is in a patient perspective too. If you don't understand what that medication is for, and you don't understand the implications of not taking it as much as taking it, then you're not going to be part of that journey. And the communication between the doctor and the patient is absolutely key. You have to understand what's happening inside. What's the mechanism of your condition, and how will that affect you, and what will that tablet do in order to intervene in that mechanism? It's all helpful knowledge. If you have the knowledge of what's going on, you will understand and perhaps want to take it more. One of the other things that occurred to me when you were just asking the question then was acceptance of a condition. Once you're diagnosed with a condition, part of that journey initially is accepting that you've actually got a heart condition. And there'll be some patients who go home and think, I don't want to take this because by taking this, I'm accepting I've got this condition.
Yeah.
So actually having that communication and conversation with your doctor to explain the importance of it, absolutely key.
Yeah. I mean, I'm sure that Max and Steve will actually elaborate more on that. But I mean, do you think that one of the barriers in the communication is that we physicians adopt an attitude that doctors knows best and expect you to just follow the...
I think that's definitely one of the things to consider, yeah. I mean, there's been a traditional view of doctor knows best, tells patient what to do. But these days, there has to be an element of control for patients too. And the patient has to be in a position to feel they're on an equal footing with their doctor. You know, I know from my own perspective that having that communication is a two-way street and it works brilliantly. But if you haven't got an access, if you haven't got a point of contact, if you haven't got a level footing to some degree, it works less. And let's face it, effective medication, effective treatment, and effective adherence is better all round. It's better for finance, it's better for work, it's better for home, and of course it doesn't just affect the patient, it affects the family.
It's interesting, when we were sort of planning this discussion, this conversation, one of the things we really were hoping to be able to do here was to awake the patient in us, the physicians. This, when you are actually adopt the patient, and many of us have been patients for different reasons, when you actually are on the other side of the equation, then you perhaps understand a bit better this situation. So are there any questions you would like to ask Maria in relation to this point? And if not, we will perhaps Clara continue with, thank you very much, Maria, for clarifying those points for us.
So that's fascinating. I'm so happy here learning from you. So now I'm going to ask Max.
Yeah.
So Max, what are the challenges that you face living with a heart disease and your interaction with your medical team? What is your experience about this?
The problem is empathy. If you are a doctor, cardiologist, you go to your work, you are a doctor until you go home, and then you are free. As a patient, I'm 24/7 a patient. I can't take an hour off of being no patient. So that's one of the problems. And it's very difficult to go to make it clear to the cardiologist that I have also a life beside being a patient. That's one of the main reasons, I think, why adherence is very low. Because if they prescribe me 3 or 4 times a day a pill, well, morning pill and evening pill, okay. But if I go to work or to a party or whatever, where do I leave my pills? I'm always thinking at when can I take them? Where's my memory of it? So it's very difficult to see as a cardiologist that we are more than only a patient they describe a pill for. So that's one of the main challenges what I encounter.
So you mentioned something really important, and it's empathy.
Yeah.
I feel, Max, that what really is important for a patient is that they feel that they really care to the physician that is taking all of the care of the disease. And the simple regimens of administration of medications, I think this is something key. For example, I work with heart failure patients when you prescribe a diuretic at night. So this is something that the patients are not that going to take because they don't want to go to the bathroom to wake up 3 to 4 times during the night. So this is something very important to think about.
To realize it.
Yes, how easy it is to take, for example, medication so many times a day. You can make things simpler for your patients.
Yeah.
And I think this is something important.
It's one of the first steps to get a higher adherence. Because when I started with my medication, there were 4 medications during my breakfast. Hour before, half hour before, during, and after. So it's crazy. So now I take them all in one hand. And the pharmacist said, well, you're crazy. I said, yeah, but I know I take it now, and else I forget them. So, yeah, we have to look for medicines which can work together and not contra. Or really contra, then you can take it in the evening or whatever. But make it clear for the patient. But the patient is only busy the whole day with his pills, and now doing this and now doing that. And he has no time off. So his mind is always set on being a patient. And we have to
Max,
move
do you
it.
think that this system is not really prepared to actually incorporate these concepts? Because you said doctors are doctors for a certain period of time, then you go home. So in a way, I got the impression that the system has to change to really adapt to these needs that we are actually now becoming aware of. I mean, the needs existed all the time, but now that we're using so many pills, I mean, I think we have to really start thinking more in terms also, I mean, not only the person-to-person communication, but also the modification of the whole way we actually see patients, when we see patients.
Yeah, and one of the problems is, I'm happy that you are talking the patient through his meds, and this pill is for that and that pill is for that, but did you check if he understands what you told him? And I think that's the main thing during your communication. Nobody checks it. If I, with my cardiologist, he tells me a lot of things in 10 minutes time. I can't understand it all. So you can say in your report, yeah, I've talked about meds, but nobody checks me if I know it and if I understand it. So it's not one-time occasion. You have to repeat the information. And not always the cardiologist, but let it do a heart failure nurse or specialized nurse or whatever, so they can check and tweak it. Yeah. So you can...
Many of us work in a system where we are giving X amount of time to see patients, and there are certain sort of consulting times when your doctor will say only one question. I can only tackle one. Which is of your 10 questions, which is the most important? I will react only to that. Yeah. So I think we are living in a crazy world. I mean, we cannot treat patients this way. So that's what I'm trying to say. Face-to-face communication, understanding, and also what you're raising. I mean, are you checking if I understood what I told you? But I think that we have to put pressure on the system as well. Yeah. And will this need to start from medical school? I mean, I don't think that we are teaching our students.
Well, we start also on medical school. I give lessons on the University of Utrecht. But the problem is, I learn them on the school, but if they come to their in work in a hospital, they come in an old system, and the cardiologist says, well, we don't do it over here. We have no time for it, so skip it. So it's a multiple layered problem. I can't start with the patient if there's no backup from the clinic. So it's difficult. It's difficult.
Yeah.
So Max mentioned something very important. So our patients also have a life. So how did you reconcile having a life with having so many medications to take, some hours to do that? So you think that we can make life easier for patients? For example, they are combinations of medications that you can prescribe just in one pill. So you think that we can make life easier for our patients?
Yeah, one pill dose would be very great, but but it's not possible. But I think first, if you prescribe medicines, check if they know how to take in pills, because in the movies you see everybody take a pill and it gets stuck high in the esophagus or whatever. So and it's possible to take a totally full load of medicines in one swallow. So you have to learn it how to take their meds and tell them that the meds are working for the next couple of years, and then you feel better. The paradigm now is, if I have a headache, I take a pill, in 2 hours it's over. For chronic heart patients, It's far beyond the truth. So that's the problem. You have to take them every day for years long, and then you have the benefits of it. And a lot of patients don't realize it because they say, well, I feel good, I didn't take them yesterday, I still feel good, I don't have to take them today also not. Why? So that's a problem. And we have to communicate to each other from what do we want. And I know for sure that if you prescribe medicines and the patient comes back, a lot of patients don't take all the pills. I guarantee it. So, and if there's still complaints, what do? Okay, next pill. So that's the problem. I think we have to go back to the basic and talk with the patient and tell them, explain them why they need it. And I think that's the first step to get the adherence higher.
So it's a matter of perspective. So it's very important to explain all of these things. And I see that Steven is also taking a lot of notes about what we are just saying today. So I want to ask you how is to live with several cardiac conditions and how is to navigate the healthcare system?
With a bit of difficulty, especially when you have comorbidities. We touched on this yesterday in another debate, that you see your cardiologist for one thing, you see your electrophysiologist for another, the cardiologist who's treating your heart failure, your pulmonologist for sleep apnea, your endocrinolog for the diabetes. But do they actually speak to each other and talk? And I think part of the problem is understanding that the patient, and we said we didn't really want to call them patients yesterday, the citizen, the person living with the condition, is not just his illness. And quite a lot of patients feel that when they go to see their physician, they're just treated as the illness, whereas each person is different. And if we can have some kind of integrated approach where the person is looked at as an individual and treated holistically, then perhaps we will get better adherence. One other thing with the adherence and education, which Max touched on and said that in general, physicians have a hard job communicating on the same level as the patient, and that quite often the patient will just go, yeah, and then walk away and go, I didn't understand the word he was saying. What was he talking about? And I think that goes on to what you were saying about new models and new practices. In France, for example, we have actually it's very. It's not regulated, but well, it is regulated. You have to have a certificate in educational therapy, and we have workshops specifically designed with nurses and with patient experts to talk about what this drug is for, what this drug is for, when do you take it, how do you take it, what are the problems, with your dealing with it in ordinary life. So we need to develop that more, and it's perhaps, as you said, not physicians' position because they don't have any time, but maybe there should be more paramedical. Yeah.
I think that's a very important point. We really need to strive to tackle the very many aspects that actually represent adherence or are barriers to adherence. Maria was talking about many pills, barriers to communication. Max was very rightly raising the issue that physicians do not clearly understand the situation of that the patient lives 24 hours with the problem. So I think we should be pushing, and this type of initiative I think helps quite a lot. We should be pushing for a radical change. I think the paradigm has to change. We are still using a very old model of therapy. Some countries are perhaps more advanced, others are lagging behind. But I think these kind of initiatives, in a way, are actually forcing a change in the system, which is not that easy. Clara was asking about sort of quality of life. I mean, sometimes you say, well, take these 25 pills because you live longer. And the patient will say, well, I mean, maybe I don't want to live longer. I just want to live a wonderful life the time I have to live. So help me have a better quality of life. And I think quality of life is a critical issue should be a critical issue in our discussions. And again, we find the barrier of time. I mean, sometimes physicians want to engage in this conversation, but then you end up having 20 patients to see in your outpatient clinic. So I don't know if there is any suggestion on your part to how to put pressure on this.
I think it comes back to the slogan that we wanted to use, which is awaken the patient in you. It's what would you as a person, not as a physician, not as a learned medical specialist, what do you feel about this, and would you consider changing the endpoints? Because this was one of the questions that you were going to ask me, is quality of life. We, with another 3 European patient associations, did some study asking patients, and patients only, what they felt was quality of life for them, and how was it dealt with their consultations, with primary care and also with specialist care. And the result actually came out, like you said, that 50% of people say, I don't really want to live 3 years longer, which is all your medical training is towards that point, saying doctors must save lives. Whereas what was important for patients was not having their life extended 3 years. If it was meant they were going to be sitting in a chair, what they wanted was quality of life now, having the medication that would allow them to overcome the symptoms of their heart disease. It was, in particular, was heart failure, and also that would somehow overcome the secondary effects of certain drugs, such as beta blockers, which are kind of like a brake. There's a strain on quality of life.
Yeah. Side effects are another key issue that we I mean, would you like to comment on this point that Stephen is making?
I totally agree with Stephen. Quality of life is the main issue, and not the prolonging life. It's crazy that there goes a lot of money for all methods and procedures for prolonging life, while the patient says, well, not for me, it's not necessary. But why do we do it? I think we can save a lot of money and give it somewhere else, to another aspect of the healthcare, than prolonging life. And the doctors, the physicians, must get out of their paradigm of healing. They're treating a patient, a human.
Healing is a good word, because in actual fact, quality of life is healing. It's not surviving. Yeah. It's interesting because a few research studies already, but not enough, have started putting quality of life as an endpoint and not survival.
Absolutely.
Which it needs to be furthered in that way.
Absolutely. Maria, side effects, in your experience, how problematic have been with medications you have taken for your heart condition?
For me personally, I've actually been okay. I haven't had many side effects, but from the patient perspective in the forums, it's a major issue in some cases. And it's not so much one tablet, as we've said before. It can be lots of interactions between lots of different tablets. So I think the multi-pill, as you call it, or whatever, I think the combination pill would be great if that's acceptable, works, and is workable. But even down to reactions to tablets and medication, it might not be the medication, it might be the excipients, the additives within the medication, and just a change of manufacturer can make such a difference to patients. In that sense, it's ridiculous sometimes. But I think it's always about a journey with medication. You and I know from us, but tweaking medication can be a time-consuming thing. But it can work, and it can work beautifully. And when it does work, you can have a great life. We were speaking to a professor yesterday here, and he said, for example, with heart failure, you don't die from it, but you don't live with it either. And I thought that was a really good phrase. You have to have medication that will work for that individual and that will work to give them quality of life. And lastly, we did a huge survey, not too long ago on the ANOCA forums with Professor Martha Galati and Professor Noel Berry-Mares, and that was all about the impact on quality of life. And we thought we knew what the answers would be because we're patients ourselves. It was worse, far worse. And we were talking about 93% multiple consultations to try and get a diagnosis. And the quality of life was 70%, 80%, 80%, all those high figures for impact on social life, mental health, I should say, work life, home life, all these different areas. You know, we forget it's not just about our patient, it's about the family, their work life, economy, you know, it's all of those things. So it comes back to that, yeah.
Something very important is mental health,
Yes.
well-being. So you think that doctors usually consider this in the conversation with patients when we are just prescribing a treatment for a heart disease?
With the best will in the world, they don't have the time to look at that side of things, I don't think. I mean, in an ideal world, you have that scenario when your first consultation can be a very much longer one. They have time to explain, and your patient doesn't then feel the need to contact you or get back in touch in the meantime because you're on a plan. But the act of mental health, the support for depression, for a feeling of hopelessness for patients is huge, because to get diagnosed with a heart condition is one thing, but to then have to manage the journey with your family, with work, and with medication, as you say, taking multiple ones, huge. So I do think there needs to be some support for that, and I think that would also help with adherence if we could support patients in how they manage their medication, how they deal with depression, etc.
An issue which I think I became familiar with, which is minor tweaking to tablets can make a big difference. I deal with a condition which is coronary artery spasm, and patients get chest pain during the night.
Yeah.
So sometimes they are prescribed treatments which the concentration of the drug actually gets reduced during the night, and therefore they will have episodes almost every day. And then if you just simply change the timing of the administration, that will, but you only understand that if you sit down and listen.
Yeah.
And that's what I ask you, whether you still perceive that in many cases, physicians feel that whatever we say has to be taken and understood immediately. And that is a problem in terms of communication. Until you really, as a physician, understand that the patient, the person who knows what the problem, how the problem is affecting their life is the patient and not you.
Yeah.
Until you understand that, you are not going to be really offering proper treatment. So I think that's another area that we physicians need to deal with, which is adopt a more humble position in relation to in this relationship. And because it's only when you listen to the symptoms, and listening to the symptoms is critical, because you can actually implement a lot more effective treatments, because if you understand the symptom and what causes the symptom, you understand which drugs you can take. So again, this we need, but we need the help of the patient to actually engage in this discussion, and we need to be pushed as physicians by you, say, well, hang on.
I think that's it. And in 10 minutes, that's a difficult task. You know, it's a difficult task in any time, but 10 minutes definitely.
But that should not be there should not be the impediment to actually change the system. Because if we understand everything and say, well, okay, we have no time, we wish, it would be lovely, we'll never change things. I think.
Yes, but they mentioned something very important, is you can involve somebody else in the education of patients. And I think Stephen or Max mentioned the expert patients. So in your opinion, the information about the disease education is easier for you to understand in some other patient explain to you all the things than if a doctor explain, or if both?
That's the main issue. You can tell me what's a coronary angiogram, but I can tell the patient what he feels, what it means for him, and also with the results. I'm not want to sit on the chair of the doctor, but I can assist the other patients to coping with their process, with their illness. And I think that's also one of the main issues for adherence.
I think
Marie talked about that yesterday, and I alluded to it as well, is one of the growing phenomena is peer emulation, is that people on Facebook groups help each other understand understand their disease, but not in a medical way. They actually sort of compare notes and saying, have you had this? Yeah. Do you understand why you've had this? Or did anybody tell you? So there is a lot of importance on peer emulation and peer education, especially in heart failure at the moment.
So it's obviously a task for the pharmaceutical industry to help sort of making people take less pills. I mean, that's a very important aspect. There is a major push that we need for universities to change the training plans and incorporate these ideas from the very beginning. There is the need for the system to incorporate expert patients, incorporate associate healthcare professionals helping in managing this situation. It might take time, but this has to start, and nothing has started because, Steve, you were talking about these changes in France, which I think are quite important.
We go in and teach third-year medical students. We have taught, not teach, but we work with nurses on the posture. What is a patient expert? How do they integrate educational therapy? And in the university, in the medical school, we go in and speak to medical students. But I think third year is a bit late for a medical student to understand that he needs to have interpersonal skills and that he needs to see the patient as not just something out of his textbook. There is I was speaking to somebody yesterday who was speaking about a university in the UK where the patients are actually constructing the modules to teach to medical students. I think it's Keele University, I can't remember.
Yes. There are, some of the universities have actually incorporated now patients in the design of the curriculum. They're helping building the lectures and the topics and the titles. Similarly, I think clinical trials are incorporating now patients because this perspective is absolutely essential.
I'm working on one which really touches me personally. I will be starting in the autumn. It's on whether or not for male heart failure sufferers we can reduce beta blockers to enhance libido, because it's a major problem for heart failure.
Right.
So the patients have been included in that, which is good.
Yeah, we are seeing a change. And again, I think that this initiative of the World Heart Federation, supported by Sevilla, is really very, very important. It gives the opportunity to us to think, help other people sort of initiating a change. I think that things like this should be replicated everywhere. I mean, I'm really fighting a little bit to try and get a similar reaction in my local place of work. So barriers to communication have many reasons. I mean, Maria, you started elaborating on this issue, and then we ended up with sort of how you explain things to patients. What other problems have you experienced as a patient in terms of finding communication with your physicians difficult? Or if not you personally, your group of patients, what they tell you?
I mean, one of the big ones, which just seems a very practical thing, is getting access to a doctor. That's the first thing, and that's part of the policy situation. You know, doctors have so many appointments, but you're absolutely right. You can't say, oh, well, we've only got 10 minutes, therefore that's all we can do. We have to change that. We have to change it so that there is more than a 10-minute appointment for patients. And if that means going up to the head of policy and up further into government decisions, then that's what we have to do. Patients have to have a journey where they can access care. That's one of the problems. Where they can understand, which was what we were talking about before. And it's not just about a conversation. That's about leaflets, being in easy speak, you know, being in easy read versions, having images if people prefer image reading rather than word reading. And one word can completely throw a patient. For a doctor, they read straight through it. So communication in its simplest form, how you write the leaflets in the medications for pharmaceuticals, but also how you write information about conditions for the hospitals, because you have to understand both the medication and the condition. And on a practical level, from a doctor's perspective, you know that if you understand the medication, you can tweak very much better because you know exactly what's going on. From a patient's perspective, same thing. If you understand why you're doing what you're doing, you're happy to tweak and you're happy to push that barrier a little bit to make your life better. Communications, I think most doctors, I would like to think most doctors are very good at communicating to patients, but I do understand that that's not the case. And unfortunately, you have to have an ability, I think, as a doctor, to change the way you speak. You know, at a practical level, you can speak at a conference in one way to medical professionals, but you need to speak in a very different way when you've got a patient in front of you who knows nothing about it and who is newly diagnosed.
So the jargon is a problem. Clara, sorry.
So something that really works for us is to ask the patients, well, now I explain to you, now you explain to me.
Perfect.
What did you understand?
Yeah,
and then you get surprised because sometimes your language was not clear enough.
Yeah.
What you mean to say was not understood by your patient. So it's so important just to make sure that the patient understands what you want to say.
And what you've just said, ask the question.
Yes.
Just say, did you understand? Is there anything you need me to explain in a different way?
Yes. It's just to change the question. And my patients sometimes came to me with a list.
Oh.
So those are my questions. And I always say, okay, let's go to the list. No, for me, it's very helpful because you give the patient the opportunity to ask everything.
Yeah.
I think, as Professor Kasky mentioned, if we have short time, well, let's use this time wisely and make sure that the patient gets the most of this opportunity to interact with them.
I think there's also a false economy in this time element thing, because if you are in a position to offer a longer appointment, you don't get the repeat visits from that patient. So there's a false economy to say 10 minutes only and out the door. Because if you can spend longer time with your patient, you don't then have them emailing, phoning, calling, desperate to the GPs, 50 other appointments to get back to you again. It's a false economy for a quick 10 minutes appointment, I think.
Your win time.
Yes.
I've actually trained my cardiologist.
Oh, really?
Yeah, because he was very young and he had this attitude of not looking at me as a person or whatever. And now when I go to visit him, he says, "Hello, Mr. McCarry, how are you? What can I do for you today?" You know, it's like, well, give me the list, what's been going on, and I'll listen to you, which is perfect. Just on the other point of doctors' time, I really think that nurses, and I have a few friends who are here who are nurses, it's a very underused profession, an abused profession, if I can say that. And I think they have, in France, we have this idea of a specialist nurse, not particularly in heart failure or heart CVD, but somebody who has done advanced procedures. And they are now allowed to do the titration and stuff in the place of the cardiologist. And I think that takes a burden off of your profession, but it also valorizes, gives them, you know, they really enjoy that as a job because they feel that they're participating and functioning. And to be honest, nurses have those interpersonal skills, and they are also see the patient on a long-term basis, you know, frequently or once every 6 months, whereas the cardiologist is, because of the appointments, it's once every year.
Exactly. And in relation to that, one of the, and this is a question for the three of you, and maybe Clara would like to chip in. I find sometimes one big problem with prescriptions, which is that patients go out of hospital with a list of medications, and they are supposed to be changed, up titrated, down titrated by the GP. And this never happens. Because sometimes the GPs are not, they don't feel confident that they can do that on their own. How has this impacted on you? Do you recognize this as a reality?
Definitely, yeah.
Yeah.
That's definitely a reality for patients. You assume at first that you can just go back and get it changed, or you can go back, make a quick call and say, actually, it's not working, or can we up to... It can be months before you get that actual change in medication for exactly that reason, because the GP will say, oh, I don't really want to touch this. I think I'd wait till you see your specialist and we'll let them do that. But you know that that's 6 months away. So you say, well, can we bring that appointment forward because I can't take it or because of whatever. And you cannot get the appointment brought forward. So you're then speaking to a nurse perhaps who are great, and they'll say, I get what you're saying, but you really need to see the specialist.
You may stop taking the medication.
This is
because,
exactly
well,
what
hang on, I
happens.
mean,
Yeah.
I'm not going
Yeah.
to have a headache for
Yeah.
every single day for 6 months.
And let's face it, if you feel bad because you've got a condition, especially a cardiovascular condition, and you take a medication that makes you feel worse, you're not a family unit, you're not working, it's affecting you to a degree. It's not surprising that you'll stop taking it.
So adherence goes
Through the window,
down the-
yeah, absolutely, yeah.
And the other issue, Stephen just mentioned that when you are seen by so many doctors,
Yeah.
EP, cardiologists, endocrinologists, sometimes the other specialists change something,
Yes.
and the patient is missed in the middle of everything. So I ordered something, but somebody else changed the treatment, so you are lost and you don't know what to do.
Yeah, I mean, I personally wouldn't be lost, but then again, I'm not your typical patient because I look at it and go, okay, right, fine, and then I inform my GP about things. But there is, it's still got to do with time. We were talked yesterday about guidelines for CVD, guidelines for heart failure, guidelines for kidney problems. So if somebody has got all those comorbidities, the poor GP takes 27 hours to read the guidelines. So we have to be realistic. And one of the things that was suggested yesterday was, why don't we just have a combined set of guidelines for CVD, and kidney deficiency as well. The other thing is GPs...
Can I interrupt on that point? This is another fight we have because clinical trials are done in large numbers of patients with a specific condition, as clean as possible. So you get a result which has a lovely p-value, so you are confident. But then you say, well, what about the other group of patients? Well, then you have to do another big trial. When you're actually confronting your individual patient, this patient has everything.
Yeah.
So you need, as you say, 10 guidelines to be able for the physician to be able to implement that. Sorry to have interrupted, but this is a thing we recognize.
The other thing with, and I hope there are no GPs listening to me, but sometimes the GP, I have seen situations where the patient tells me that the GP knows better than the cardiologist and says, no, we're going to change that. He's got it wrong. You really don't have to have a high dosage of diuretics because it's making your blood pressure go down and everything. But like, he's a specialist. He said, no, rubbish. So you have to deal with that as well. And that is misinformation and lack of communication between hospital and town situations.
This morning, one patient was also presenting his experience about living with heart disease, and he spoke about an initiative like guidelines translate for patients, like in a simple way to explain patients why they are taking those medications. So it's an initiative that I think it's also very important because you are just showing the information in a different way. And it's so important that patients really get informed about all the possibilities and all the treatments that can have for the heart condition.
Interesting what you said about all of the eventualities, because yesterday what we discussed was the relationship between kidney disease and heart failure or cardiovascular disease. The fact that kidney failure often leads to CVD, but it also works the other way. But nobody talks, when you go to your doctor and you say, okay, well, they don't want to say, well, you might have end-stage heart failure where your kidneys give up. And it's like, why don't you tell me that? It's so I can prepare as a person for that eventuality. And where am I along that line? That's something that is overlooked. We tend to, with CVD, we tend not to. Well, the general public are not aware of the extent of cardiovascular disease and that it is a #1 killer, more than cancer. And I'm not taking anything away from cancer. But we go up front with cancer patients, say, well, you've got cancer and it's, you've got this chance or this chance or this chance. With heart failure in particular, which is my thing, is that sometimes we don't even refer to it as heart failure, and we don't, which is also an adherence problem, is we don't actually pronounce clearly that it is a deadly disease if not managed. But it can be kept under control. So people are not aware of the fact that they have this life-threatening disease. They just think it's your heart's tired.
So that would increase adherence if you were aware of each of these.
I think I would. I think so. And I would like to know, right from the outset. Which was a question I did ask in a moment of depression, was how long have I got to live? And the answer was, how long do you want to live? I can't tell you that, which is fair enough. But it's like, tell me where I am on this scale of disease so that I can deal with it. I can prepare for it. If you're telling me that I need a transplant, but I'm too old, then let's talk about how we can deal with that in another situation. It's only fair.
Very important.
I don't know if maybe we have some questions from the audience to our expert patients. We have some time to discuss some other things that you want to know.
Don't be shy. I'd actually like to ask Clara.
Okay, you can ask.
The job. I got a question. One of the questions you wanted to ask me was, can you define quality of life? Can you define what quality of life is for you, not as a doctor, but as a person?
For me, quality of life is to have the ability to do the things that you like to do. This is quality of life.
Well,
Yes.
You have the answer to the
Yes.
question. It's exactly the same for a patient. What did I say the other day that you repeated? This is my life and I want to live it, I want to live it as full a life as possible. Within, we understand I'm not going to get any better, but maximize the ability to do those things.
And sometimes we are not allowing you to do that. Because
barriers
down
the road. So
exactly,
that's
because of the
problem.
barriers we discussed today. I mean, I'm pretty sure that every single doctor would really like to contribute to that and make you live the best quality of life possible for you. It's only that there are so many barriers that we have not identified, only now identifying that we are not contributing to improving quality of life in many cases, despite being willing to do so. So, again, I'm very repetitive, but I mean, the initiatives like these, I think, are helping us enormously, because you open new windows, you open new gates. Even if we don't have the answers and we don't have the system, then I'm sure that tomorrow we'll have a lot more enthusiasm and feel empowered to actually suggest change.
I'm actually smiling because I'm just remembering a post on the Facebook page where somebody asked the group, I have heart failure. I also have another condition, which I can't remember what it was. Can I fly? And everybody answered, well, as far as I know, yes, you can. But why don't you ask your cardiologist for precise details? And the answer was, if I ask my cardiologist, I will not do anything in life, because he will say no, no, no.
Oh, no. I will tell you the top 10 of questions that I have also very young patients. They ask me if they can jump from a parachute, if they can dive. So a lot of questions, things that you never think about, and you need to do some research to see. But say no and close the door is not a good attitude.
The person's going to do it anyway.
But an important part of the quality of life that this patient would like to
And I
live.
think part of it too is, it's not just patients who are facing barriers. We get that the doctors are facing some of those barriers too. It's about us working together to get rid of them. I mean, Inoka patients have an added barrier. Doctors don't even believe it happened. It's an actual condition.
And I want to ask Stephen.
Yeah.
You said that you are not the average patient, and you certainly are not. You have educated I know. You have educated several of your physicians. They interact properly.
I think I know where you're going. Go on.
No. What I mean is, how successful have you been, and how many people have you upset, or in general the response is good? No, it is an important thing to know for cardiologists, for physicians to know.
I have the unfortunate or fortunate fact that I'm half Italian, half Scottish, so I go ahead, and if I offend you, sorry. I've had one or two. I don't think the majority of people, especially in the medical profession, have been against it. I have one or two sort of like, who do you think you are? Sort of think, you're just a patient, you know, but these are types of doctors who will say to a nurse, don't do that, you're just a nurse, you know, which is unfair on them. I think in general people listen, but the problem, I mean, I work on advocacy at political level as well, and it's a very, very slow process to get people go, yeah, but act on it is a totally different thing.
But in general, you have been able to generate the change in at least a proportion of the people who have interacted with you. So there is hope for people to actually change the system.
I'm very impatient, but I've learned that, you know, like for example, today and yesterday, speaking in ESC in Amsterdam is a big step. And I thank you for inviting us all. But it has to go further.
Indeed.
And we'll continue.
So,
I'm not going away.
So we love your perspective. This is something wonderful. So maybe Max or Maria want to add something else?
If you ask me, is there hope for change? I think yes. In the Netherlands, we are busy now with revising of their curriculum for the medical students. And in the third year, they have the first real contact with patients. And now we're trying to get patients from day one from the training, as well in the bachelor, as well in the master curriculum. So it's a lot of work, and for us as patients also to think about it. What must the doctor know, and what skills must he possess over 4 or 5 years? But it's very encouraging.
Good. And for Maria, with INOCA International, do you think that you are making a contribution to actually break these barriers that actually reduce adherence? I mean, is the sort of communication within the social media community helping patients to break these barriers, is helping them to change the attitude of physicians?
More than you can imagine, yeah. I mean, even the simple questions in the forum are watched and read and heard by everybody else in the forum, of course. And as, Stephen mentioned earlier, it can be the simplest question. You know, how do I take this? Do I take it before a meal? Do I take it after a meal? And patients come into the forums not knowing how to take their medication. They've got all the details. They've had their appointment with the cardiologist. They've seen the nurse, and they still come in and say, but what do I do about this? But how do I do this? But where do I go for this? And the lovely idea of this is they go out saying, I feel so much better, I can do that. So they're adhering. Adherence is all about understanding, and it's all about provision of knowledge and information and the things that will help adherence. I read 35 million cardiovascular events per year. I think it was in the heart roadmap. And 40%, 20 to 40% of secondary prevention. Adherence is massive. And if you're making the medications, if we're treating the patients, if we're bringing them in, we need to make sure it's effective.
Yes, so the only pill that works is the one that your patient is taking.
Correct. Well said. Yeah.
So this is something that you really make to make sure in every interaction with your patients.
Yeah. Well, that social environment, you're quite right. The social environment means they can just chat. They don't have to be talking in any sort of doctor-patient or nurse-patient environment. They can just chat as people.
Just peer.
Yeah, and sometimes it's just support.
Yep.
They already know the answer. They just need you to reassure them.
Reassure me.
Yeah.
Yep.
Put yourself in the patient perspective, I would say to doctors. What would you want? What would you expect? And what would you like to hear if you were the patient at the other side of the table?
Any question from the audience? Oh, the microphone is
Thank you
coming.
very much for your fantastic discussion. Do you think that if there is any, I don't know, technology or any like iPhone application, something like that, can be also a tool which can help to have information or to collect something which can be discussed with doctor?
On digital health, you mean, that sort of thing?
I'm speaking about, for example, iPhone applications, some
Apps and things like that.
technology which
I
can...
think if it's applicable, you know, I don't think it's good to give an 80-year-old something to do at home on the app. They're not going to use it, and if they did use it, it would cause them such stress. But I think if it's appropriate, and if it's applicable, and if it's simple to use, simplicity, keep it simple. But if you can self-manage, self-management is great. It takes the pressure off doctors, it takes the pressure off the medical health profession generally, it takes financial pressure off. So if it's possible to do it and it's easy to use, it gives control back to a patient, and I think that's big.
Those ifs to me are so critical,
Yes.
because we see we are inundated by devices and apps, and you can download, but you ask most people who are above 60 to actually go and use it, and they will find it very difficult and perhaps not appropriate. So I think Maria says, I mean, if they are appropriate, they're ideal. If they're not, then we have to really go back to the traditional thing, which is talking to the patient and speaking and listening and incorporate new people who can help us.
I think that's a valid point about going back to tradition and talking to patients. You know all of this because we've discussed this anyway. But there is a backlash towards technology at the moment. For example, when you sign on to something and they ask you to validate who you are by a robot and wait for an email to come in, I just get the impression I'm wasting time. It's like, well, that's another 15 minutes of my life that I'm not going to get back. And in particular for apps, if we start talking about chatbots and things, which is a different situation at all, with artificial intelligence, then there perhaps is light at the end of the tunnel for that, but there's a lot of work got to be done on making it relevant to the person. But in terms of apps, I've been in situations in congresses where we've sat down and somebody's going, well, I've just created this app for the patient, and all the patient has to do, and I'm like, that's not all the patient has to do. Being a patient is a full-time job. That's just another thing that's hindering me making the bed. You know, put it into context. If you inundate people with apps, they're just going to go like Marie said. They won't adhere.
And it won't be. It may not be a substitute for contact with the patient.
Exactly.
That's my fear always, because if I get an app, they say, oh, you can all do it through the app, and I think, no, I want to see the doctor, because I not maybe. Not so often, but I need contact.
Yes, I was going to ask you about telemedicine because, I don't know, in Latin America, the patients really love to be examined by the doctor, to get in touch with the doctor. So how did you feel about telemedicine? Do you think it's a good solution?
Telemedicine is for me possible. In the Arabian states, they work a lot with telemedicine, and it works there. But it's also a question of, do you educate the people with it? And it's a change of life for all the people. So you can't say, well, we do now telemedicine, and it's okay, you do it with it. And I think you have to learn, Stephen, do you know how it works?
Yeah.
Now you can ask a question. And then we can go further in the education.
Just ask people how much they like banking online. They would love to see more branches in the streets, but we're moving just in the other direction.
Yeah.
So I'm a bit conscious of the time.
The other thing is, for me, it seems obvious that the solution is not one or the other. It has to be a combination.
The combination.
And perhaps digital healthcare has to be a sort of, not a substitute, but a complementary. Yeah. As they say in, in France, they say a béquille, which is what do we call it? A crutch, thank you.
Yes.
Is something that you can rely on to extend the care. And the thing about people wanting to have more branches, quite often now, I think people have understood who have online platforms that you have the chatbot that gives you answers which have got nothing to do with your question, and then it goes, I see that we can't answer your question. Would you like to hold on and I'll put you in touch with a human? And that's like, well, please.
Absolutely.
Because I can resolve the situation in 30 seconds with a human, but not with a computer who doesn't
Yes.
understand me.
Okay, so time flies. It was very interesting to have you today here with us. We learned a lot. So please listen to your patient. The patient should be in the center. The patient needs to communicate better with us. We need to make sure that patients understand what we teach them, and also adherence is critical. If you don't take a medication, it's not going to work. You need to understand everything, and we can make life of our patients simpler, just adjusting the regimens of the treatments, and this is going to improve adherence. So thank you very much for being today with us.
Thank you very much.
It was a very
for the
interesting
opportunity.
conversation.
Thank you again to the World Health Federation and
Yeah.
Serbia for organizing that.
Absolutely.
Thank you very much, guys.
Thank you. Thank you so much.